Good morning, everybody. Thanks for showing up so early. I'll try to speak well for 2 hours. If I start getting tired, just throw something at me. But we'll take a little break in the middle. Just wanted to first thank my staff at Restore. I always forget to do that, so I'm going to start off with that. We have a wonderful group of physicians and practitioners that are helping build this new practice model, and we'll talk a little bit about that as we go. But just want to give them a shout out, and we'll start. Okay. This is my family, so wife, dog, 4 kids. So they were really excited about my show and tell this morning. So last night they said, "Dad, I have a really good show and tell," and that's kind of what it is. It's we'll talk about some of the science and other things like that, but basically I'm going to tell you a little bit of my experience. A lot of this stuff is somewhat anecdotal. Now we're going to look at some imaging and talk about interventional pain. There was a lot to bring together, and there's a lot more to discuss, but what I wanted to start off with something that we see a lot of, that you're going to see a lot of in your clinical practices, pretty much any specialty that you get into, and that's going to be low back and spine pain. So we'll focus a little bit on that, but we'll talk about the importance of some of the adjunctive things around dealing with pain and sports medicine. What can I impart on you today? And my hope is that we'll learn a little bit of science. The other thing that we'll want to do, and we may want to turn the lights down at a certain point, is do what you believe in. And so you guys are, it's exciting to see young, enthusiastic physicians of the future that are coming into this, into this world, and to give you a little bit of insight and inspiration into do the things that you want to do. Obviously, there's a system out there. You're already, a little bit adventurous in your spirit to do naturopathic medicine, and continue that, believe in what you're doing. Dare to create your own path. So something that is out there, you're going to have all of this education and people coming up and telling you all of this dictum and these facts and how to practice medicine. And obviously that's going to build your foundation, but remember to create your own path. If you do what's truly making you happy and doing the things that affect your patients, you'll be happy, because there's going to be tough times. There's going to be times you're working really hard, too many hours, not enough pay, and if it's something that you don't believe in or not happy with, it's going to affect your life and everybody around you. So do those things. Remember the safety of your patients. That's paramount. So all the things that you're doing, make as sure as you can that you're keeping them safe. Some of these things are, especially in my line and my practice, we have branched out in some of the regenerative medicine techniques, and we've gotten some flack from the community. My training is in allopathic medicine. I'm an MD radiologist, so one of the most kind of black and white fields that you can get into. And we've pushed those boundaries, and we've gotten some flack for that. But the tenets that we always keep are to make sure that your patient's safety is paramount, and the first thing that you deliver is that. Remember, do no harm. Continue to push yourself. Gain that knowledge. Go to courses, CME, use PubMed, and try to keep if they have a proxy server, some access to literature. When you get out into the field, it's something that you need to always look back into. And if you have access to journal articles, you have access to those things, whatever, if there's a local library or something with your medical institution, continue to do that. Also reach back out to NCNM when you're out in the community to be a teacher, to allow, to further that information that you're gleaning to the next generation. Use your colleagues, journal clubs, those types of things, and try to get involved in the research. There's a lot of neat things out there with industry, with private individuals, and even within the practice that you're performing with. Try to keep information. A lot of that information can be looked at retrospectively. You're going to start to see patterns of thought. You're going to see patterns of theory and treatment, and you want to keep those that information. So EMR, those things are helpful with that. But even if you don't have that, make a system. Use an Excel file. Use Word to keep that information. And then do the best to treat your patients. Use your humanity, humility, and love. I see this too often, especially in the allopathic world, where some of these things are lost. Treat other patients like your family. Treat them with humility. Admit you're wrong. There are times when you don't know the answer, and instead of brushing them off, just tell them. And I don't know the answer. I'll try to look this up. I may not have the best information. And then use your resources. Don't be afraid to say, I may not be the best person for this, but I know someone else that can help you. And allow them to get that information. And then finally, just treat them with love, and all this other stuff will happen. All right. So one of the things I wanted to do, it's 7:35 in the morning. What I'd like to do is have everybody here who's ever had a pain issue, low back pain, that may not be something that has persisted or you've seen, sought treatment for, but anybody that's had low back pain or back pain in the past 2 years, please stand up. All right, that's scary. You guys are so young. Start stretching. No, that's so. Go ahead and sit back down. This will get some blood flowing. Good. So that's low back pain. So probably 70%, 67% of you stood up. How about any of you that have had joint pain? Shoulder, knee, ankle, wrist. Please stand up again. We'll get the. It's the same people. Yeah, exactly. Yeah. So it is. I think in part we're such an active society, and in Portland here even more so. It's wonderful for your musculature, heart, lungs, those types of things, but it can wear down those joints. You have injuries, and some of these things can become chronic. The lifetime prevalence of back pain in the U.S. is between 60 and 90%. 14% of people will experience back pain episodes of up to 2 weeks or longer. And it's the second leading cause of absenteeism from work, causing 25% of the missed days of work. Can have a large effect on the disability and chronic disability prevalence. This is some information, and I'll try not to show you too many charts, but it was just interesting. This is data from 2012, and this is age-adjusted, self-reported medical diagnoses or conditions. And it's a little bit hard to read, but it's musculoskeletal, emotional, circulatory, sleep, respiratory, migraines, diabetes, cancer, cognitive disorders. And you can see here, this is per 100 persons. Over 50% are reporting that they're having, and we can see that in this classroom, are reporting significant musculoskeletal issues. So obviously this is a huge part of our societal drain and societal effect on medicine. This is prevalence of self-reported MSK diseases. So these are the different diseases: chronic joint pain, arthritis, neck pain, low back pain, and low back pain spreading below the knee or radicular type symptoms. And you can see here what I thought was interesting. Obviously there's per 100 patients, or per 100 persons, a lot of folks that are affected. But there's age distribution: 18 to 44, 45 to 64, 65 to 74, and 75 and over. One of the things that stays relatively constant from a 24 to a high of 32 is low back pain. And so we're seeing that. You're a very young population here, and we're seeing that you can be quite affected by this. This is a comparison of musculoskeletal, circulatory, and respiratory diseases, and spread out over the different age groups. And you can see again, the MSK starts at 42 over 100 and increases, and only after 75 years old, 75 years of age, do we see the circulation or circulatory issues overtaking musculoskeletal problems. And so this is patients over 18 years of age in different areas of musculoskeletal joint injury or self-diagnosed pain. You can see that knee, hip, and shoulder dominate. Okay, and that's what we most often see in the clinic. And this is not just arthritis. This is soft tissue injury, ligament sprains, strains that sometimes start out acute and then become chronic. And here are the effects societally and the gross domestic product of the U.S. And you can see from 96 to 2011, it's steadily increasing. And this is only going up with the baby boomers and the effect of increased utilization of surgeries, total knees, total hips, and even arthroscopies. This is also indicative of the societal costs of medicine, so pain medicines, anti-inflammatories, the celecoxibs, as well as opiates. So this is a very big issue. Those 4 girls that I showed you in the beginning, they're going to grow up in this country, and I'd like this country to be a good one. And the societal costs of medicine definitely pose a challenge. And so what do we do? This is $850 billion just in musculoskeletal healthcare. This is direct costs as well as lost wages, lost time at work. So what we have tried to create, and what we're creating at RestorePDX, but also in this community, is a more holistic and interdisciplinary approach. We're trying to be cost conscious, and this is what I'm going to harp on you a little bit, is this diagnostic-based medicine. And I think too often that we're treating symptomatology, and we're not digging deep and finding out what's actually happening to this patient. Why are they having this disease process? And then What I'm very into and excited about are the regenerative medicine types of therapies, and we'll talk about that. So fancy word, interventional pain management, sports medicine. What exactly is this? So it's basically image-guided diagnosis and therapy of commonly encountered pain syndromes. And this can be chronic pain, this can be pain secondary to athletics, in the sports medicine arena, and really focused around spine, joints, and soft tissues. Where do we fit? So this slide's a little bit hard to see, but you have this painful patient right upper corner of the circle, and they often seek conservative therapies. If their issue lasts long enough, they're bothered enough, it's affecting their lifestyle, they're going to seek therapy. And they're going to seek that through their primary care physicians. They may go to chiropractic, massage therapy, acupuncture, physical therapy, occupational therapy. And most of those patients are going to do very well with those conservative therapies. Their problem is going to be identified. It may be a self-limited issue, and they're going to come out of this circle or continuum. It's those patients that have failure or limited success that we have kind of intercepted or started to see. And basically our goal is to, at this point, they've tried these conservative measures, and this may be for weeks or months, and we're trying to find out why they're having these issues. Okay? And so we utilize this multidisciplinary approach. So we're seeing the patients, doing as good a physical examination, neurologic examination as possible, taking a good history, and then if they need the imaging, we're going a step further and trying to identify the injury. If it's something that can be treated with minimally invasive means, that's what we're doing. If not, we're at least triaging them to the right clinician, the right service to get that fixed. And so if we have failure or limited success, then they may move on to a surgical consultation. They may move on to a psychological consultation, so depending on what issue they're dealing with. So a patient comes into your office, seeks care for a particular painful region. What are we looking for? And I think this gets lost, especially with what I've seen with residents or newer physicians, or even in the primary care setting, because you're handling so many different things, is we're not going after this. Okay, and this is the diagnosis. I think it's really important. Oftentimes we're looking at the symptoms, and we're simply treating the symptoms. They have this issue. They have shoulder pain. What are we going to do? Okay, we'll prescribe them for some physical therapy. I'm going to give you some anti-inflammatories, maybe some muscle relaxers, and we'll see you in 6 weeks. All right? Shoulder pain diagnosis. Has that been worked up? Has the proper physical examination been done? Why are they having the shoulder pain? Is it coming from their neck? Is it adhesive capsulitis? I mean, there are true diagnoses that need to be sought out. And the same thing exists for low back pain. I think for low back pain, it's even more difficult because there's so many mimics. Okay, and so then we're going to talk about some of those things. And just to reemphasize, if anybody has any questions as things come up, please just stop me. I'll reiterate the question, so we'll have it recorded, and then I can try to make an intelligent answer. So the right diagnosis, and this is important too. How do we get to the right diagnosis? So these are all important things, and I think are lost, unfortunately, because we see a lot of these referrals. We see a lot of secondary referrals come in. Sometimes we're the last resort. But patient history. So really dive into that. When did the pain start? Why did it start? How long has it been going on? What are exacerbating factors? Has this been treated in the past and gotten better? Has it been treated in the past and not gotten better? All of that's going to give you information. And you have to go into the old records. It's very difficult for patients to remember all the things, especially if it's been a chronic issue that have been done. So it's on your onus to call those facilities to try to get as many records as you can. That's going to guide you, because they may have had, you may be thinking in a certain line of therapy, they may have had all those therapies already performed and failed. So you may need to start thinking of novel approaches, or we may be barking up the wrong tree, right, as far as their diagnosis. Physical exam is very important. And this is coming from a radiologist, right? So I give you a little bit of background for myself. When I started practicing 6 years ago, I came out of an interventional musculoskeletal radiology fellowship. We were sent patients to do procedures on. So the doctors would, from the clinic, they'd see somebody that was hurting, they'd send us a patient, we'd do an epidural, I'd consent them and send them back. Read all the imaging, MRI, CT, X-rays, those types of things. When I came out to private practice, started seeing the same type of thing. We were starting an interventional pain practice. Physicians, clinicians would send us patients, and I would be able to interact with them a little bit more in that setting, a small private practice. And they would come in and I would start talking to them about a certain issue. We were going to inject a facet joint for back pain. I'd look at the imaging and I'd talk to the patient, and they were having lancinating pain extending down the leg, numbness and tingling in the toes. and they wanted, they were coming in for a joint injection in the back. It wasn't really the right injection. So I talked to them, take time, examine them a little bit, and I'd call the physician or clinician and say, hey, can we move this to an epidural? I think it might be a little bit more effective. And they said, sure. So this started happening with some regularity, and I would keep calling, and then they got sick of me. So I said, please stop calling. Can you simply see the patient? We're just going to send them to you. And I went to my boss at the time and said, can I see a patient in clinic? I don't know how to exactly do that. Do we have to do this and that? And so we started actually seeing the patients. So they're like, yeah, you have an MD. So I thought, all right, let's see them. So we started working on that. One of the biggest things in my challenge the last 7 years, and I'm still working on this, is the physical examination. And it's a really important thing. And each year, I seem to add something to that repertoire. Something becomes more solidified in my mind. And it takes a long time. I think in medicine in general, we have lost this art of physical examination. And especially, I'll speak a little bit for the allopathic field, not as much for you guys, because I'm not sure about your training, but I see it in our field, is that we have really lost that art. We rely so much upon imaging. We rely so much upon the other arts that we have, labs, diagnostics, that sometimes we forget to put our hands on the patients. We have a new PA that's joined us from the neurosurgical world, and I have a chip on my shoulder because I'm a radiologist, so I try to make my physical exam as good as I can, that she was very surprised at our level of acuity for our physical examination. And so over the last couple of years, we've started to use a lot more tests for SI joints. Imaging has changed. We'll talk about that. And we've seen a lot more correct diagnoses, and better therapeutics. Imaging. I think I'm very biased, obviously radiology training, but the imaging nowadays is quite fascinating and very elucidating. There are 3 Tesla MRIs, or very high field strength MRIs, as well as musculoskeletal ultrasound that's giving us a lot of information. The interesting thing that I've noticed in the past is that there is a large disconnect between the imaging and the clinicians. And so that's something that our practice, and we're going to develop more and more of these type of practitioners, is the connection between the imaging and the clinical side. There are times when most of the musculoskeletal radiologists, most of neuroradiologists in the country are reading for surgical diagnoses. Right? They're being sent cases by neurosurgeons, by orthopedic surgeons, even by pain medicine physicians, but they're looking for surgical outcomes. They're looking for disc herniations, they're looking for things that are broken or fractured and need fixing. What they're not looking for is sources of pain. And that's been something that I've noticed over and over, that we see patients, the diagnosis is screaming at you on the MRI, and it has not been discussed or touched upon at all. And so that leaves the clinician in a really bad spot, because the clinician, they don't know how to read the MRI. They don't have that training. They come in, they're referencing that imaging report. So they go see all these things. Okay, disc herniation C5-6, and that's what the source of the pain is. Where they may have a raging inflammatory arthropathy, they may have ankylosing spondylitis, they may have something else that's actually driving their pain syndrome, but this is never discussed on the imaging, and it's there. So that's one of the things and that's the onus on the radiology side. And we've been discussing this. We're publishing some papers and abstracts as well with Dr. Wright, one of your colleagues, and talking about the importance of this. Diagnostic and potentially therapeutic injections. So this is something that we do when we have the information. We know that we're looking at a source. We've done all these other things. And sometimes, especially with the age of the spine, somebody that comes in and sometimes age is 35, sometimes it's 85. But that person comes in, they have multiple issues. They have disc disease at multiple levels. They have multiple level arthritis, SI joint issues, soft tissue issues. Where do we start? Again, we use all these things, and sometimes we need these injections to help us guide where it's coming from. And so these are diagnostic, and I always cross my fingers, potentially therapeutic injections. And so we're trying to figure out what the source is. Oftentimes I'll use corticosteroid, because right now in the insurance world, those types of injections are paid for. Unfortunately, the regenerative medicines currently are a cash pay item. So we want to find out if we're going to use those regenerative medicine techniques, spend the patient's hard-earned money, let's make sure it's in the right spot. Okay, we're going to have the best effect, they'll be happy. And then follow-up. So just doing an injection and sending them on their way is not enough. We do a pretty rigorous follow-up. We have pain diaries that the patients take home. They fill those out. So if we're doing a particular injection, we want to see what's happening. What gets better? What doesn't get better? What are the side effects? What are the issues? That can help glean things, because sometimes maybe there's 3 or 4 bad actors in the spine that are contributing, and maybe all those issues need to be addressed. So what does the wrong diagnosis do? And this is the sad part. Prolongs the pain and suffering, improper injections or therapy, and more unfortunately, improper surgeries, which we see all the time. A very gross issue that we see not uncommonly, it happens a few times a year, is somebody getting a spinal fusion or vice versa, a hip replacement, and it was the other issue that was causing the pain. Okay? And then you go back in their chart and nobody even did an x-ray of the hip, or nobody evaluated the lumbar spine for any pathology. They came in, they talked about it, it seemed like a good story, we'll set you up for surgery, you know, you failed this, that injection, and off they go. And they don't get any better. And now they may even have a new issue, right? So new issues or new problems that the patient didn't have before. They didn't have pain in that area, now they do, plus they have their old pain. Or the bad outcomes with infections and other things. And this leads to this narcotic use and overuse, and something that we don't believe in. We very sparingly use narcotics after regenerative medicine procedures. We don't use it as a chronic pain medicine for chronic pain. Why don't things work well? We talked about this. Lack of communication between providers. And this is not just between the imagers and the clinicians, but this is amongst the actual clinicians. So this is something that's very important. It is hard because, you know, when we suffer from the same issue, you have a busy day of clinic, and you need to connect with someone to talk about, does this seem appropriate? Should we move this way, or do I need to send it back to you? You need to connect with the other clinicians. It's difficult, but try to make that happen. It's going to be really important for your patients. There's fundamental issues with fee-for-service, and this is changing over time, but we are incentivized to do more procedures. We're incentivized to do things. So if you are a surgeon, or if you're an injectionist, the same way, people come in, that's what you're incentivized to do. You need to keep the doors open, and you need to do these therapies. And so what we're trying to do is move towards outcomes-based or global type of payments. And I think that's important. So if we can show that this type of therapy is more effective, or we're getting people better, faster, for cheaper, it's going to be much more effective, and that's going to help society in general. And then we talked about this disconnect, and we're both responsible. So we're trying to do our part for this. So here's a very biased opinion, but finding a trusted musculoskeletal radiologist, if you get into the sports medicine or interventional pain field, which there'll be plenty of work to do, find a good radiologist to work with. It's going to help. You don't need them all the time, but when you have those difficult cases or you want to find out what type of imaging you need to do, it's always helpful. This is a completely and utterly biased opinion, but shockingly not all MRIs are read correctly. They're not performed correctly with the proper imaging tools, and they're not diagnosed or read correctly. The other thing that, with this, I'll take the blame as well, even within our own practice, there are times when I have the referring clinician, if our nurse practitioner, Jeff Grimm, if he orders something, or we have Dr. Bennis, he's a DO, or Dr. Anderson, who used to be with us, they would order studies. And I would try to read their chart notes before I dictate something to find out what they're looking for. But there are times when their hands found something on the physical examination that they would come in and talk to me about, and I had missed things. And I said, well, you're right. There is a little bit of inflammation in that joint. I think that's probably where it's coming from. I'll dictate an addendum. Okay, so that's okay. But having that interaction with your radiologist is very helpful. And again, remember that out in the community, wherever you practice, you guys may be all over the country, remember that there is a bent for your radiologist to read for surgical diagnoses. So start maybe looking at those images, taking a look, and we'll start that process today. So back pain, lower extremity pain. What are you looking for when that patient comes in? And I try to break it down into these main blocks. Okay? Mechanical. Is there a mechanical disruption? Is there a disc herniation? Is there scoliosis? Is there some kind of instability? Do they have a pars intra-articularis defect or spondylolisthesis? They have something structural that's wrong. Did they have a cam type impingement of the hip? Is there something else structurally that's affecting their pain and causing this? This can, and it's closely tied with inflammation, because they can have some mechanical disturbance, but usually, and it's not going to start to become painful unless there's a certain degree of inflammation. It may, still with mechanics, but there is oftentimes an inflammatory component. One of the things that's going to be very effective is high field strength imaging with fluid sensitive sequences. Sounds fancy, but basically we get to see inflammation. With the MRIs, you get to see where fluid is. You can, and I'll show you the images. So it's very sensitive in picking up areas of inflammation. So you can look at all the labs and different things and talk to the patient, push on them. But there are times, and sometimes I feel like MSK radiology and pain radiology is quite simple. All you do is a really good fluid sensitive sequence and then look for the bright spots. because that's where usually inflammation is, and oftentimes that's where the pain is. Neuropathic pain. So this is something either a systemic issue with vitamin deficiencies, diabetic issues, and it can be from chronic compression or neuropathies. If a patient has had a spinal issue or stenosis for long enough, they're going to affect the dorsal root ganglion. They're going to affect the nerves. And these may be a chronic issue where it's a neuropathic pain. And you may not see anything on the imaging. You may see secondary signs of why something's happening, but you may not pick up why exactly they're having the pain. And oftentimes this is a rule out where we have to use EMG, nerve conduction studies, and then just good physical examination, and there's some exclusion criteria as well. And then psychologic. And this is an important thing and something that I'm working on personally to try to understand this more and get patients the right resources. Probably one of the biggest things that's lacking currently in our practice is an in-house psychologist for sports and pain, but I think it's very important. And this plays a huge role. There's fear and avoidance behaviors that occur. There's a lot of other things that will affect the patient, that if this chronic pain has been going on, they're going to restrict their body's motion. They're going to create secondary effects that may not be there based on this. And so this is something to look at as well. And you have to talk to them about their family situation, the stresses that are upon their life. And we can see this with our patients, that we know they have some structural or inflammatory neuropathic issue. But when stress increases in their life, if they have a death in the family, if they have something else that's going on, their pain increases, and they're seeing us more often during that time. And to affect that, it's very important. You guys will have some of that training as well. But remember that side. All right, so the bony anatomy, we're going to go through this quickly. How much training do you guys have on spine anatomy by now? Pretty solid foundation? Yeah, okay. So I'm going to go through this pretty darn quickly, and then we'll get to some of the imaging. We may turn the lights down when the MRs come up. I don't want you to fall asleep, though. Anterior middle columns, all right, so here and here. So you have the vertebral bodies, anterior longitudinal ligament, and the posterior longitudinal ligament. In the posterior column are the facet joints, ligamentum flavum, and the posterior elements. So those are two areas where the anterior middle columns and the posterior columns where we can derive axial low back pain. We also talk about the SI joints, and this has become more and more apparent in our practice that I was missing a lot of this. Through my training, I was missing a lot of this, and it's become something that's important to me and making sure that this is evaluated, because we are making wrong diagnoses. The SI joint, small range of motion, is where your spine meets your lower extremities. The S is for the sacrum, inverted triangle here, and then the ilium. Small range of motion, but it can become very painful and can mimic low back pain. One of the things that we have noticed this year, we treat a lot of SI joint disease, is that if somebody has a radicular symptomatology pattern, like a pinched nerve, don't rule out SI joint. It can present exactly the same way, and there may not be any disc pathology, nerve root impingement, but don't rule out that it's not coming from the sacroiliac joint. It's not just localized to the buttock or low back. The anterior portion of the joint is inferior and anterior, and it's a true synovial joint, and about 75% of the joint is posterior superior, is fibrous and ligamentous. And that's also does play an important role in the pain generation. So don't think the pain just comes from from the joint. The neural anatomy, the central canal. So that's going to contain the epidural space and the thecal sac. It's bordered by the PLL and the disc, pedicles, and ligamentum flavum. So any of issues with any of these structures is going to cause issue with the central canal, and we'll talk about that later with a central stenosis. The epidural space, so it's from stem to stern, contains mostly fat and epidural veins. So it's an access site that you can put medicine in. And they put morphine and other medicines in a catheter for pregnancy. What we do is we're able to access this site and put in medicines such as anesthetic and corticosteroids, and now even platelet-rich plasma and other things to try to affect a change on those tissues of the nerves and the discs. Okay? The thecal sac contains the cord and the nerve roots. And remember, the cord ends approximately L1, and then you have the conus medullaris, right, that terminates, and then you have the filum terminale, which are the nerve roots that are dangling like a horse's tail. And those go down into lumbar and sacral levels. So now we talked about the central canal. And these are the neural foramen. This is a sagittal view. And you have the nerve root and the dorsal root ganglion coming out, two at each levels bilaterally. And there's quite a bit of pathology that occurs here. And so you can imagine everything's so close together. We call this kind of on the MRIs, you'll see a pork chop view. This fat will be bright, and you'll see the nerve root like a dot. Kind of looks like a pork chop. And this is kind of a happy nerve root, right? It has lots of space. This is all soft fat and has the small arteries and nerves, siniovertebral nerves adjacent to it. Over time with disc disease, you can see this disc. If it starts bulging, what's happening? This area is getting smaller. This is the facet joint. If that starts to get arthritic and hypertrophies, that area is getting smaller. So all those things occur, and if this disc is getting depressed or smaller, then this space in a craniocaudal or vertical dimension is also getting compressed. So all those things can cause compressive neuropathies, and we'll take a look. So we try to break down acute and chronic. Anything over a couple of months goes into the chronic phase for low back pain. And then we also try to do axial and radicular pain. So is it localized to the low back, localized to a certain region, or are they having pain that's shooting down the leg or the thigh? It doesn't have to go all the way in a certain pattern, and it can also skip. So if a patient comes in and they have some low back pain, plus or minus, and they have neuropathic type pain in the foot, don't exclude a causative agent from the spine. It's not always the case that it has to go all the way down. And so remember, any innervated structure in the spine can cause low back pain. All right, this is kind of a busy slide, so I'll go through this quickly. But acute, we talked about axial. So musculoskeletal, myofascial, muscular spasms, fracture, infection, neoplasm. So remember those kind of bad actors too, the things that are red flags, something that you don't want to miss. We've seen those cases as well. The radicular or radiating pain in an acute sense, so a herniated disc, infection, neoplasm, and then referred pain from organic issues if they have aortic issue, vascular issue, if they have a tumor in the liver, if they have retroperitoneal adenopathy. There's some other issues that can cause this axial low back pain. So look for the other things. Have they had a history of recent weight loss? Are they having any other issues? So all those things come into the history as well. And then chronic, again, you're looking at discogenic, joint-centered, so facet or SI joint issues, pars interarticularis pain. So those patients that come in 12 to 20, remember, look for those pars interarticularis defects or spondylolisthesis or spondylolysis. So it's very important. So they'll present younger patients, low back pain, and they can often have symptoms down into the legs as well. One example, we had a patient that came in, a 17-year-old female with severe calf pain upon any activity. She was an athlete, had been very active, and now even walking up a flight of stairs, severe leg pain. She'd been worked up in the community for a compartment syndrome. Really didn't fit the picture because she didn't have to take many steps to get the pain. Compartment syndrome is vascular engorgement in the calves, after high level activity, and there's poor drainage, and you have pain in the lower extremities and paresthesias. It didn't fit that picture. We even did an MR to look at the lower extremities. She did not complain of back pain, which is a difficult thing, and I think why it took so long for us to diagnose this. But after a while, we started talking and kind of doing more and more physical examination, just ruling out other causes. We had to look at your back. There's just nothing else that seems to be causing this. Was unrelenting. So we scanned her back, and she had bilateral pars defects, and there was really no slippage, and there was no nerve compromise, but the facets or the pars defects were edematous. There was inflammation. We treated her with bilateral epidural injections just to see if this pain would go away, and she had over a year of relief with those injections. And so even just the inflammatory component of those pars defects were causing that. So bracing, conservative management, and activity modification were prescribed for her, and she's doing better, but she's still dealing with some of those issues. Okay. We talk about radicular or radiating pain, so nerve root compression, neoplasm, and spinal stenosis, so neurogenic claudication or radiculopathy. Okay. And so axial low back pain mediated by the siniovertebral nerve. So this is a small branch. So here's an axial view of the spine, vertebral body, central cord, and there's the nerve root that's coming out. It sends off posterior division and anterior division. The anterior division sends the siniovertebral nerve that feeds the disc and the soft tissues around the disc in the epidural space. So this is what transmits discogenic pain. So people talk about disc pain or disc issues, and now we're going to see more and more of this. That we're starting to use platelet-rich plasma and stem cells for regenerative therapies for the disc to try to heal them and reverse the course of injury. But this is the nerve that mediates the pain for that. So you can see how close everything is here. This is the spinal nerve, and this is the posterior division of the spinal nerve, and that feeds the facet joint and the deep musculature of the spine, so the multifidi. So this is the medial branch, and you'll hear a little bit about in pain medicine where you can burn this with radiofrequency ablation. So if you have arthritis in the back and it's unrelenting, it's not being helped. There's not a lot of surgeries, other things that help currently in our allopathic scheme. And what they do is they go into this nerve, we know where this lives, and you can burn it with radiofrequency heat. And that can basically disengage the nerve or stun the nerve, it doesn't kill it, for anywhere from 6 months to 2 to 3 years. And that's been used as a fairly effective therapy for facet arthropathy. The concerning thing is, what else does this feed? Right? This medial branch comes off here. It's getting those deep multifidi. So if somebody comes in and they're 35 years old and they have low back pain and it's facetogenic and they have inflammation, and you do a cortisone injection, they feel better. And then the next step is, but it doesn't work forever. And you don't want to keep dosing them with cortisone. What they can do, the next step in the standard model, is to do these radiofrequency ablations. Now, you're helping their pain for a bit, but what else are you doing? You're denervating this muscle. And what we're seeing on follow-up MRIs is early edema within the muscles, and then over time they're starting to get fatty infiltration and atrophy. So now what's the effect of this is destabilization of a young spine. Okay? They're guaranteeing them surgeries in the future. Okay? So that's where we have to be thoughtful about what we're doing. It's not always the best situation. Now, if somebody comes in, they're 75, 85 years old, and they have severe facet arthropathy, and they have low back pain, and you do a cortisone injection, it helps, but it works for 2 weeks, and they come in, this may be a good therapy for them. Because really there's a lot of deconditioning anyway, there's no joint left, it's probably better than a fusion, and if you can get away with burning something and it works for 6 months to 2 years, it's probably an okay therapy. Okay? Because you avoid corticosteroids, you avoid opiates, you avoid other things, you're making them functional, and they can work on the musculature they have. So if they have pain relief and a pain-free window, then you get them back into activity, get them into pool work, core strengthening, those types of things, they can be very effective. So the other thing is muscular spasm. It's probably a little bit overdone. We see a lot of patients that are described as myofascial pain, muscular spasm, piriformis syndrome, those types of things. And it all sounds good, but there's a lot of true pathology underlying this that is underdiagnosed or misdiagnosed. And that's the concerning thing, that we see these patients come in with localized spasm and then they do tons of therapy. Nobody is bothered getting an image. And then we see them kind of spit out of that system when they say, okay, it's been a year, I can't help you, it's not working. Why not get that person evaluated a little bit earlier? If we do scan them and yes, there's nothing there, fine, continue the therapy. If you look at the costs, an MRI probably costs nowadays anywhere between $500 and $1,000 for a lumbar spine MRI. Okay? The physical therapy sessions themselves cost patients about $250 per session. So if you're doing twice a week, every week for 6 months, and we don't know what we're treating, I think it's a very ineffective use of our resources. And so this is something that's important. But there's likely little role for paraspinal muscles in chronic pain syndromes. For these short-term muscular injuries or spasms that get better in a few weeks, for sure. But once something is lasting over 2 months and not getting better and is unrelenting, I think it's your responsibility to dig in a little bit deeper, not just put them on more medicines and continue the physical therapy. Acute axial low back pain. So if there's no significant trauma, again, the treatment of, this is kind of hard to see, so oral analgesics, NSAIDs, short-term opiates for severe pain, and muscle relaxants, lifestyle modification or activity modification, and physical therapy or physiotherapy. So that could be chiropractic care, physical therapy, acupuncture, any of those adjunctive modalities I think is important. One of the things to look at, and that's why x-rays are fairly important, especially in the right patient population, is to look for acute compression fractures. Make sure this is not something more serious. So chronic axial low back pain, usually about 40% we believe is discogenic. Lumbar facet joint pain and SI joint pain come in kind of second and third. One of the things I do believe is underrepresented, and this is old data, this is coming from the 90s, and kind of your standard allopathic pain model. I think the ligamentous and the small structures around the spine really play a large role. We've seen that in some of the regenerative medicine therapies, and I do agree with a lot of the prolotherapists on what they're doing. And they've been using prolotherapy for many years and having wonderful results with low back pain. A lot of them have switched over to the platelets. They seem to work more robustly, and I agree with that. I've seen the difference, that you have more control, and I think you get a better tissue regeneration with the platelets, but a lot of ligamentous disease is ignored in the standard pain model. Discogenic pain, we looked at that sidiovertebral nerve. So here's a normal disc. As it starts to age, it starts to lose its hydration. You get little annular tears, right? The annulus fibrosus is the outside. You start to get little annular tears and degeneration. It starts to bulge. And then you can have frank herniations where that nucleus pulsus extravasates from the disc. This degenerative pattern, it starts with a normal disc. First thing that we see that disc starts to dehydrate, so it loses its water content, loses some of its plasticity, and that allows it to start bulging, okay, or losing some of that containment. And that's where the sinovertebral nerve feeds, so that can be painful in and of itself. So that's discogenic pain. You start to develop small fissures and tears, and if they become large enough, that's when you have a herniated disc. That's when that nucleus pulsus, that soft material, that toothpaste or jelly-like material, extravasates from the disc, and that's extremely inflammatory. It's very soft. So people think of like a herniated disc as causing a tremendous amount of mechanical compression. It really doesn't. It's pretty darn soft and pliable. But the inflammatory mediators that it releases, like PLA2 is one of the main ones, is very powerfully inflammatory and can cause a lot of pain. And so that's why medicines like anti-inflammatories, steroids, those types of things, it doesn't change the morphology of your issue, but it dramatically improves the pain. Why does that happen? It's because of this reduction in that inflammatory cascade. Then you have this thinning disc over time. These can resorb. You can have the thinning disc over time, and we'll talk about that resorption a little bit later. And then you start to have degenerative changes of the adjacent end plates. So now these discs are not doing their job, right? So now where's this forces going? It's going into the end plates of the discs, and you can start to get degenerative changes. Dr. Michael Modick from Cleveland Clinic was a radiologist who described these. They're called Modick type changes. So if you ever see in your reports, Modick 1 is edematous. So that's the first thing that we see is edema builds up in these end plates, and you can see that on the MR sequences. And those can be painful. It's like a stress fracture, stress reaction. The second type is fibrofatty change. So you start to get this higher fatty signal intensity. It's more of a chronic issue. And then finally sclerosis, where it gets dark and hard because now the end plates have been taking this abnormal stress, and you get these osteophytes. You can see what happens to the neural foramen, right? I mean, that's a nice neural foramen here and here. Here you start to see that little lipping, the osteophytosis, and the narrowing of the neural foramen, and that becomes this chronic compression of the nerve roots. So MRI has gotten a really bad reputation for back pain because we see it, we see too much almost. It's very sensitive, and it's hard to be specific with the MRI and the clinical exam in isolation. Now, bringing them together, I think it's very helpful, and we can become much more effective. So we look at 20 to 40-year-old. If we scanned many of the folks out here today, think about that. 35% of you are going to have discogenic pathology. You may not even be having back pain. A lot of you do. Who knows if it's from the discs, but that's what we're seeing. As we get to the 50s, 60s, look at that number jump. 85 to 95%, pretty much everybody is going to have disc pathology. So that's the hard part. If somebody comes in, and this is a lot of our patient population, is over 50, they come in and they have back pain, you're going to scan them. You're guaranteed to find something, right? You're guaranteed to find something. But is that going to help you guide your therapy? Maybe not. And so that's why it takes the physical examination and really correlating where are you having this pain, what type of pain are you having. And then the last thing is looking at that inflammation. Those fluid-sensitive sequences that I spoke about before can be very helpful in determining where you have the pathology. There are patients that come in that have really bad-looking herniations on their MRIs. Their pain is axial. You look on the MRI and there's one facet joint that's inflamed and angry. You treat that facet joint, all their pain is gone. They may have had that herniation for the last 2 decades, but it's not bothering them, right? So you have to use these things wisely. Here's this, we just talked about this discussion of the morphologic changes of the disc. So this is a sagittal view of the lumbar spine. So vertebral bodies and the discs. Here's a normal disc. You can see this is a fluid-sensitive sequence. So fluid is bright. So fluid in the CSF, right? Fluid in the disc. This is the first thing that we see when the discs start to degenerate is this dark signal, so dark discs. And slowly you'll see a little bit bulging. This is the anterior longitudinal ligament. And you can see here, the posterior longitudinal ligament, and you can see here the bulging of the disc, lifting of that ligament slightly. And here you see the progression where it's dark, it's a little bit smaller, and then you see the herniation. So that's kind of a progression of this process. This is a hotly debated topic in radiology, these annular tears, or what you might see called high-intensity zones. So we'll see these not infrequently, and we're not sure what to do with them. Some of the older school docs believe that these are totally unimportant. They're there, they're a sign of aging, but they're not symptomatic. I'm on the fence. I don't know, because what I've noticed is these small tears, they can be painful, but a lot of times we're missing the other pathology that's actually causing the pain. It could be myofascial, it could be SI joint, it could be a facet that's angry but not overtly inflamed. It could be psychological, so it's really difficult. So you see these, we take it with a grain of salt. I'm on the fence at this point. So you'll see these little white areas, these annular tears in the outside of the disc. And it makes sense theoretically that you have those sinovertebral nerves feeding that. So if you have a small tear there, obviously there was some increased pressure, there's localized degeneration, that can be painful. So you can look at those, but they're also hard to treat. What do you do with that? Usually we've relied upon epidurals to bathe that area to see if we can reduce the pain. The facet joints are true synovial joints. We have 2 of them at each level. They have cartilage and adjacent bone. And then any process, arthritis, inflammatory arthritis, injury, can cause these to be painful. And usually that's going to be a localized axial low back pain that can radiate into the buttocks or thighs. This facet joint pain is mediated by the medial branches, those branches that we saw coming off the spinal nerve. That's what's transmitting the pain to the brain. And so if we see this, we're not able to treat the joint locally, then that's one way to block the signal. But we were talking about the potential ramifications, and you can see the area that it's feeding on the multifidi and the musculature around the spine. This is a fluid-sensitive sequence, and this is what we see. And so this can be very obvious to a trained radiologist that you're looking at the lumbar spine. These are the discs looking down the barrel. Sorry, these are the facets looking down the barrel. And see how bright it is here? That's all fluid. That's joint, that's too much. So that's inflamed facet joint. So you can see that's 5, 4, 3. So 2, 3 facets bilaterally are really inflamed. Can we turn on the lights for just a moment?